The sign-in code for this presentation is 4429.
Alrighty, everyone. So hello and welcome to our third Journal Club meeting. Tonight we'll be talking about tolerance of face coverings for children with autism spectrum disorder. Tonight, Dr. Bellotti and I were going to tag team this one, but she's feeling a little bit under the weather. So I'm just going to take the lead on it, and you guys can jump in and ask questions at any point. You're welcome to say them out loud or put them in the chat. I have my phone open to the chat, so feel free to ask away during the presentation any questions that you guys have. So the article we'll be talking about tonight was by Halber and colleagues. This is the CEU sign-in code, if you guys want to take a moment to write that down. It is 4492. Remy, I'm glad you got to see my video presentation about mask tolerance. I hope you enjoyed it. All right, I'm going to move on to the next slide. You guys can let me know if you need the code again. So being a couple years into COVID now, we have a good idea of signs and symptoms of COVID. There may be symptoms like fever, chills, cough, shortness of breath, fatigue, muscle body aches, but it's important to remember that COVID affects everyone differently, and some people may get minor versions of these symptoms, while others may experience more severe reactions to the virus. These are some recent data for Hillsborough. So for those of you who live in the Hillsborough region, this is what's going on in your region. You can see that it is a high transmission region, and the CDC is still cautioning everyone to mask up in Hillsborough, which makes sense because it's a highly populated region and growing more and more population-wise. I think that Dr. Bellotti just pulled these data from the CDC website. So if you guys want to check out your own individual reasons and see case numbers and transmission status, you can do so on their website. So again, being a couple years now into COVID, I think we are familiar with the importance of wearing a face mask. They help protect not only ourselves, but those around us as well, which is important given the population that we work with. A lot of our clients having other health complications or other comorbid conditions. On the right side are some recommendations for mask wear. So making sure that the mask that you wear fits snugly around your nose and chin. Masks with breathable fabric. Also, 2 or 3 layered masks are also recommended. This slide goes over some reasons why mask refusal may occur, and it's very similar to other tolerance literature in that it's most likely occurring for escape and avoidance purposes. I won't say escape is the function in 100% of cases because I saw some other possible functions while I was doing mask tolerance research, but it's highly likely that it's escape and avoidance maintained. There is a really informative review on medical compliance. It's by Allen and Kopsick in 2016. The citation is on that third bullet point down there if you guys want to take a look at it. And they discuss how individuals with ASD exhibit higher rates of avoidance and noncompliance to basic medical procedures compared to typically developing children. And they discuss how this may occur due to intense and unfamiliar sensory experiences. So wearing an object that covers where you breathe over the mouth and the nose may be an unfamiliar and intense sensory experience for some. Mask removal or mask refusal may occur because the mask is seen as an aversive stimulus that is unfamiliar and unpleasant to wear. So even if the individual doesn't have a history of engaging in avoidance or escape behavior to avoid or terminate mask wear, it's possible that they may have engaged in similar problem behavior to terminate other similar aversive events. I can't speak for the authors of the other studies, but for myself, at the time of the study, at the time I conducted my mask tolerance study, there were no behaviorally based mask tolerance studies out there, even though mine was the fourth one published. I was working on it while the other authors were working on theirs, so there wasn't much to draw from. So I drew from the medical tolerance literature, which has assessed techniques to promote tolerance to different procedures. And the other studies, they do mention other tolerance work in their introduction, so I believe they drew from that field as well. This is not an all-encompassing list, but these are a few behaviorally based treatments to help promote tolerance. We have graduated exposure, which you'll see, I think on the next slide, is the most commonly used intervention. Escape extinction, video modeling, in vivo modeling. The high probability sequence has been used before, and also distraction techniques as well. Here is a summary. This is based off a lit review I did a couple years ago, so some of the numbers may be a little different now, but it's a summary of different interventions that have been used. You can see the most common is graduated exposure. And if you guys haven't heard of graduated exposure before, it's basically slowly exposing an individual to a feared or an aversive stimulus or stimuli, whether that is through slowly increasing the proximity of the stimulus to the person, so the distance, or the size of the stimulus, presenting an increasing number of steps in an exposure hierarchy, or a duration-based exposure method as well, which is what we're going to talk about tonight. But some of the other common techniques, so after graduated exposure, we have modeling, differential reinforcement, escape extinction is pretty high. I think from that Allen and Kupsik review, escape extinction was used in like 32% of the studies that they reviewed. Also distraction techniques, which I know has been used in some of the dental tolerance literature, the high P sequence, non-contingent escape, picture schedules, and also social stories. So in the Halber study, they do present their graduated exposure hierarchy, but I wanted to give you guys some examples of other exposure hierarchies that are out there. The Halber one, I think, is 15 steps long. There's other much longer graduated exposure hierarchies. This is from a Cavallari et al. Study who taught tolerating steps to a routine medical evaluation. So you can see how each step that's involved in the medical evaluation is listed in the hierarchy, just from sitting in the waiting room to tolerating the instruments. And in this hierarchy, steps are broken down into sub-steps, which is really common. These particular sub-steps, I'm looking at, I think it's step 7 there, require the individual to tolerate a stethoscope for an increasing amount of time. So 1 second, 3 seconds, 5 seconds, 10 seconds. So again, just taking an entire procedure and breaking it down into really small steps and sub-steps if needed. This is another example. I know this text is small. I hope you guys can see it. I tried to highlight some salient pieces in those red boxes. But it's taken from a Kuvo et al. Study where they looked at complying with a lung examination. So going from tolerating the stethoscope just in the room to tolerating on their chest, and then eventually adding in those deep breaths. So you'll see some similarity between this exposure hierarchy to the Halber et al. One, where they have tolerance to just the feared or the aversive stimulus being in the room before moving on. These are different mask tolerance studies out there. It doesn't include mine, it's not on there, but we can go through these a little bit. So Savarman et al., theirs was the first one published in 2020. They had 6 children with autism spectrum disorder. Their intervention was graduated exposure, which we just talked about, with contingent reinforcement, modeling, and instruction. Their terminal goal of mask wear was 10 minutes, and they also looked at generalization probes with different mask types in community areas. And they found that all 6 of their participants were able to wear the mask for 10 minutes, and 5 out of 6 of them demonstrated tolerance in a novel setting. I'm going to skip the Halber study because we're going to go into that one, I think, in the next slide or two. And then another mask tolerance study was Lilly et al. In 2021. They looked at mask tolerance with 6 children with ASD. Their intervention was a little bit different. They used a DRO intervention, or differential reinforcement of other behavior, and their terminal goal was a little bit longer at 30 minutes. And they also did generalization probes in novel settings, but they found that their participants were able to reach that terminal goal of 30 minutes. Questions, comments, anything that you guys want to talk about or bring up so far? We're about to go into the study next. All right, so this is the study that you guys read for tonight, is that Hallie et al. 2021 study on mask tolerance. So some background on the Hallie et al. Study. For reasons we talked about in the beginning of this talk tonight, individuals with autism may have some difficulties with tolerating face coverings, which is a problem because then they could be excluded from different settings like schools if they're unable to wear their masks as well. Not mentioned in the Hallie study, at least I don't think it was, but also hospital settings. At the time that I did my mask tolerance study, I was working in a hospital, and providers actually weren't seeing patients unless they could tolerate a mask on their face. So it's really important to teach kids these skills so that they're not excluded from different community settings. Some background literature on Hallie et al. So they drew from a couple different studies. The first was a Cox et al. 2017 study, which taught children with autism to tolerate MRI and reduce motion during imaging, which I think is really cool. They used graduated exposure, least to most prompting, and reinforcement in the form of edibles and praise. So drawing from some graduated exposure literature there. And then also the Savarman study, which we just talked about a couple slides ago, where they taught children with ASD to wear face masks. And the Savarman study was done all via telehealth. It was all remotely. Some components of that study, they did preference assessments beforehand to deliver preferred items, contingent on compliance to mask wear. They did smartphone images and telehealth demonstrations of mask wear, which I think is a great idea. They also went over the purpose of mask wearing before starting, which I think is something that could probably be evaluated as a separate intervention in and of itself. And also caregiver implementation of a 15-step graduated exposure hierarchy using coaching and prompts. So the purpose of Savarman was to partially replicate a behavioral treatment package composed of graduated exposure, prompts, and differential reinforcement, similar to the Cox et al. Study, and also extend the treatment package to teach children with autism to tolerate face coverings, and then also replicate some methods of the Savarman 2020 study with the addition of escape extinction during treatment. They did add escape extinction procedures. Participants included 12 children with autism. It was across 2 clinics in the Midwest. 9 participants were in the clinic, 2 were completely telehealth, and 1 was clinic and then ended up switching to telehealth. Materials used were face masks. I believe the 3-layer surgical face mask, and then they also did probes with face shields as well, and also their data collection materials. This is a breakdown of client description in terms of age, gender, ethnicity, diagnosis, BB-MAP level, any previous tolerance training, which is important. I love that they included this table, and in my experience with publishing research, there has been such a huge push for more of these data in terms of participant characteristics when submitting research, which I think is a great direction that the field is going in, just to get more background information on characteristics of participants who are taking place in this research. This is the 15-step graduated exposure hierarchy they used. So you can see it starts with just reinforcing, picking up the mask, bringing it closer to the participant's body. So some of that shaping by proximity that I had mentioned before, touching it to their face, hooking it around just one ear, hooking it around both ears, tolerating it for increased durations of time until that 5-minute goal is reached, that 5-minute terminal goal. And on the right side are the steps for the facial shield, which follows a similar structure of reinforcing closer distances, placing it on the face, and then longer durations as well, again, ending with that 5-minute terminal goal. These are the IOA and treatment integrity data across participants. Both were pretty high across IOA and treatment integrity both. Building off of the treatment integrity data, these were the integrity components that they were taking data on. So it's a little bit hard to see. So whether the correct ASD was presented, if the experimenter was starting and stopping on the correct step, how the experimenter responded to problem behavior, providing the correct consequence, and so on. So different components on the researcher's behavior. This is a little bit difficult to see as well. If you guys want to have the article pulled up at the same time, you're more than welcome to, so you can follow along. But this is a list of modifications that had to be made throughout the study. So just to give you some examples, for one participant, they had to remove step 6 in the hierarchy because his face shield didn't have a strap on it, so they had to modify that. For the same participant, they had to add a hands down rule in physical prompts because he was pulling down his face mask when talking to someone. For another, they had to switch to telehealth at the end of the hierarchy due to COVID, so a couple procedural modifications that they had to make throughout the study. All right, so we will go into the results next, and I want to get a little more interactive with you guys here. Does someone want to interpret the first participant's results for us? Carl's results. If you guys like, I can do the first participant as a model, and then someone else can go for the other participants.
I'll take a crack at Carl's.
Yeah, go for it.
Sure. Okay, give me a second here. I'm on mobile, so it's very, very small. I have to read the text.
Is that Jared?
Okay. This is. Hello.
Hi, Jared. If you want to start with just orienting us to the axes, so what we have on the X and and here we have a primary Y and a secondary Y. So
sure. It looks like the X is session and the Y is steps tolerated.
Mm-hmm. And then we have another.
Let's see, going down a little bit further. Oh goodness. Okay. You said there's another X-axis.
Another Y-axis.
Oh, another Y-axis. Okay, let me take a look.
Yeah, it's probably difficult to see on a cell phone.
Yeah, I can hardly read much. I might need to phone a friend. Oh, I see. Behavior per min. It's over on the right side.
Yep.
Okay.
Yep.
All right. So what is it? Frequency data on the right for behavior per minute.
So would that be a frequency, or what would we call that?
Maybe not.
Response over an amount of time starts with an R. Rate. Yes.
Oh, great. Oh, thank you. I should know that.
That's my friends
okay.
are.
Yes.
But thank you.
So it looks like the treatment with a face mask was successful for increasing the steps tolerated for Carl with face mask. I see the single, what looks like a face shield probe.
Yep.
My screen's a little too blurred for me to see what the straight line is in the legend beneath face shield. I can't quite read it.
Let's see. So we have face mask data are the closed
Triangle.
circles. Face shield data are the open circles, and those are just the probes. Target step is the horizontal line, and then blocking is the line with the X through it.
Okay. Well, from the best that I can see, it looks like there's an increasing trend with low variability, except for towards the end of the first treatment condition for Carl.
Yep.
And it looks like he hit, at least at the end of the first treatment, steady responding with a significantly increased steps tolerated.
Mm-hmm.
Are you looking for more than that?
Good. That was good, definitely. Yeah, so for Carhill, good job, Jared. Let's see, he tolerated, just starting in baseline, it looks like he tolerated about 8 or 9 steps. It is a little bit difficult to see with the mask in baseline, and maybe 6 or 9 steps with the face shield. And then just like Jared said, treatment data show tolerance gradually increased. There was a bit of a decrease around step maybe 13 in the hierarchy, and then they do master the hierarchy, and then those treatment extension data. Who wants to, so Jared, you talked about the data, that was very nice. Who wants to discuss what those treatment extensions were from the article? There was a treatment extension 1 and a treatment extension 2. What were those referring to?
Wasn't it referring to trying to get them to keep the mask on for the first extension was for 5 minutes extra, and then the second one being for 15 minutes extra?
Perfect. Yes, good job. So we have some data from treatment extension 1 there, which is the 5 minutes, and treatment extension 2, which was the 15 minutes. And those data show tolerance up to, looks like maybe step 10 with the face shield when the treatment duration was longer. And then maybe all steps with the face mask on during the second treatment extension. So all in all, it looks like Carl did very well with this. Thank you guys for participating.
That's what I'm here for.
Appreciate it. All right, who else wants to interpret some data? And guys, there's so many graphs. There's this one.
I'll take a stab at one.
All right, do you want to pick a certain participant?
How
I'll go through the graphs
about,
again.
how about
I don't think we'll have time to go through each participant's data, but I'll let a couple people interpret data.
Okay, I was going to say, I'll just go with Elias.
Okay, awesome.
It took a while for baseline to settle down. But once it did, it was a steadily increasing rate of responding. And it looks like he topped out right at 15 steps.
Mm-hmm.
And in the treatment extension, I maintain that for the most part.
Mm-hmm.
Although, and this is something I noticed about the others too, is the treatment extension seems to be where the blocking is happening.
Mm-hmm. Yeah, so it seems like when those sessions get a little bit longer, then it might be more likely that the individual's problem behavior or rates of blocking, trying to block the mask being put on, goes up. It also looks like for this participant, they didn't see too much of an increase with the face shield compared to a mask. It looks like they did a couple probes during treatment around the beginning and at the end, and it seems like they stayed about the same. It's hard to see, it maybe went up 1 step or so, but the face shield data looks about the same there.
Yeah, it looks like also with the telehealth sessions, the first one, there was a bit of a dip in responding, but they caught back up pretty quick.
Mm-hmm. Nice, good job. Thank you for participating. Let's see. It's got some interesting data here we could talk about. Let's talk about Wendell's data. Who wants to talk about Wendell? This will be the last one, and then we'll move on.
I can go for it.
Awesome.
Okay, so in baseline, we see actually an increasing trend, it looks like, with regards to the face mask probes. And then there's differentiation between the face shields and the face masks. And that seems to maintain across even when treatment begins as well. The face shields, the behavior doesn't seem, or the skill doesn't seem to generalize once treatment starts for the face shields. But we do see, doesn't seem to change much at first when treatment begins, but eventually we do start to see an increase in that behavior, and then they do reach all 15 steps within the treatment. And then across treatment extension, initial treatment extension, we see a decrease. They don't meet all of the steps, and then eventually they do reach that. And again, we do see that blocking start once the treatment extension starts again.
Awesome. Yeah. Thank you so much, Dr. Moore. Does anyone have anything that they want to discuss or bring up about these graphs or any of the participants' data in general? Anything that you may have found interesting or surprising that you wanted to talk about after reviewing these data?
Doc, I was wondering while I was reading it, they did the 2 treatment extensions with 5 minutes and 15 minutes. Do you think that by any chance they would have been possible if they are better results if they would have did 3 and they would have did maybe 5, 10, and 15 instead of increasing it by 10 minutes? That was just a random thought I had while I was reading it when I was reviewing the data, that's all.
Yeah, I see where the thought is going there, like increasing that duration a little bit.
It just seemed like a large jump in my opinion, from going from 5 minutes to 15 and not maybe doing like the 5-minute intervals. So I was just curious.
Yeah, I think just based on the data that we're seeing, the going from the 5 to the 15 minutes was successful for them. And I mean, I wasn't a researcher on this study, but I would surmise if they had started to, or if they had seen a really big decrease in mask tolerance during those treatment extensions, then they would have shortened the total tolerance duration.
Okay, thank you.
Yeah. All right, so next up are the duration results across participants. On the left column, we have the participant, the middle is the treatment duration, and the left is the total duration in treatment, which includes baseline and generalization there. So you can see for treatment duration, which again was total time in treatment, we have, let's see, minutes that range from, on the low end, it looks like, 25, Alan was pretty short with 25 minutes there. And then on the high end, we have 66.8, so close to 67 minutes there. Then total duration time, 4 minutes. Let's see, on the low end looks like 89. And then on the high end, we have 96, I believe. And then for Ryan and George, I believe those were participants who didn't complete treatment. They had to drop out. So that's why they have the NAs next to their name. Okay, before going into full spectrum COVID policy, which we'll go over at the end, I didn't put any discussion slides in. I thought maybe we could do more of a general discussion, points that you guys found interesting, anything that you guys want to talk about, have questions on, if there's anything from the results or discussion that you guys want to talk about. You know, if you were the researcher, would you have done anything differently? Things like that. We can just sort of have an open discussion.
I think as far as opening a door, there's a lot of other procedures or prosthetics or use of medical devices that could be researched as far as how well it generalizes.
Yeah, absolutely. I think that's a fantastic point. Corey, could you think of some other applications of where we could use this? Or it doesn't have to be Corey, anyone else?
I just know from some of the kids I deal with, keeping their glasses on.
Yes. Yeah.
In a colder climate, wearing their mittens or their hat.
Absolutely. That's a great point. Really anything that they might find to be aversive, any other duration based procedure may need to use. So maybe tolerating a seatbelt for an increased amount of times, tolerating wearing a helmet, things like that. Corey, your applications were fantastic. I completely agree. Dr. Bellotti posed a question. Has anyone taught clients how to wear masks? And if so, what have you found to be successful?
I had a client about a year and a half ago. We got the wear a mask. The first thing we did is we let him pick out it. It was not a super good mask. I'm going to be honest, but it was a step in the right direction. We let him pick out the fabric that he wanted. His mom took him out and got like a fun little Pokemon design. And then he got to assist his mom with cutting it and making his customized mask just for him. So I'm not quite sure in clinical terms how I would put that, but having the kids super involved and making it a fun art project made it a little less aversive for him when there was a finalized product. And he wore the mask around, but it was just a cut, like soft piece of a t-shirt, really. I don't know if it actually stopped the spread of COVID, but it was a lot better than having no mask when he started. We couldn't even get him to wear it for a couple seconds.
Yes, absolutely. And I'm so glad you brought that up, Jared. I think choice is really important. And just from, again, some of the mask tolerance research that I did as well, we didn't collect any formal data on mask choice because at the time at the hospital I was working at, they just had the standard like child size 3-layered surgical mask that they were giving out to everyone. But after a while and once COVID continued, a lot longer than some thought it would. Parents wanted to, try the use of other masks, cloth masks, things like that. And we started incorporating choice for some of our clients at the hospital once the study was over. And most of them did pick cloth masks over surgical masks. And this study, I think it may have talked about it in the discussion a little bit. They talked about some other behaviors that occurred while participants were wearing the mask, so fidgeting with their masks a lot. And they talked about, I can't remember if it was this study or another study that talked about mask mouthing. And a lot of my participants were engaging in mask mouthing as well, which was essentially just like sticking the mask into their mouth and sucking on it. And we found that the type of mask actually made a pretty big difference there. And it wasn't necessarily one more so than the other, but some participants were more likely to mouth their cloth mask and some participants were more likely to mouth their surgical masks. So mask type, preference, those all play an important role. Has anyone else taught mask wear, mask tolerance?
Somewhat similar to, I believe that was Jared speaking earlier. I had a client that we learned he didn't like wearing the mask because he didn't like how it felt behind his ears. So we did an arts and crafts session. We decorated the mask that we got from Five Below, like a mask kit. And then we were able, his mother and I were able to finagle the mask so that it would like attach to his hat because he also really liked wearing hats. So
Oh,
he would tolerate wearing the mask, but he didn't have to worry about the cloth behind his ear, and it was just attached to his hat and that seemed to work. I mean, he still wears his mask, so.
yeah, that's great. Yeah, so important to assess some of those more like idiosyncratic factors with what certain individuals find to be more aversive versus less aversive. One of the kids that I worked with did not like their ears being touched either. Fortunately for me, they had actually just gone through a tolerance study previously to do ear checks, like at the doctor's office. So that had pretty much been worked through. But if they hadn't had that tolerance training, then I would imagine that I would have had to do something similar there. That's a great idea though, attaching it to the hat. They have those little connector things that you can put behind the head and like attach it to the connectors as well. Some of the people that I used to work with would wear those because it does start to hurt a little bit behind your ears when you wear it for too long. Awesome. All right. Well, thank you guys for sharing these points. Corey, did you want to say something?
No, sorry, I hit the wrong thing.
No worries. We'll do a little bit of review of the FSBA COVID policy, and then I can actually show you guys some interesting data and videos from the mask tolerance study that I worked on. So we will, again, briefly go over some FSBA COVID-19 policy. So just remember, if you or a member of your household are feeling ill with symptoms of COVID-19 or come in close contact with someone who's been diagnosed with COVID-19, make sure that you contact our district director, Dawn, at the email shown there, and also your direct supervisor as well, and copy Dr. Bellotti on the email as well. And then once you've notified Dawn and your direct supervisor, you'll be contacted for follow-up by a member of corporate leadership. And make sure that you don't report to any full spectrum ABA school or private residents until directed to do so. The FSBA COVID-19 policy also has a list of free testing sites that have been approved. I think it's a lot of like CVS's and Walgreens that make it pretty easy. Mandatory procedures. So all employees and contractors are required to wear their masks that fully cover their nose and chin. Make sure that you're wiping down your workspaces, your materials. I know that a lot of times we use the same materials between clients, so making sure that we're wiping those down. Make sure you're washing your hands regularly. You can also contact the corporate office for assistance if you have difficulty with getting wipes or hand sanitizer or masks. Vaccinated providers. So if all individuals who are participating in treatment, which means the FSBA provider, the client, any other caregivers or stakeholders are fully vaccinated, and if it's allowed in the location where the treatment is happening, then FSBA providers may choose to have close contact and not to wear a mask during the session. Even if you are fully vaccinated, you still have to complete the daily self-assessment. These are points in the daily self-assessment. So just making sure that you're answering all of the questions in there. So the type of location that you're reporting to, making sure that you don't have any COVID-19 symptoms, you haven't been advised to quarantine, anything like that. I'm sure you guys are all familiar with those daily self-assessments. So if the employee or the contractor answers any self-assessment question with a false, or if an employee or contractor self-identifies a potential exposure, a member of the corporate leadership will follow up by calling the phone number listed in the questionnaire. So those daily self-assessments do get checked. And based on the intake, the employee or contractor may be instructed to contact a healthcare professional. Then you'll be asked to confirm who you've been in close contact with, and you'll be instructed what to do from there if you do have any of those symptoms, or you indicated you do have any of those symptoms. This is the client family self-assessment, so you guys are probably familiar with this as well, but it needs to be presented to the family or the caregiver prior to starting each session. So just making sure that they don't have any COVID-19 symptoms as well. If a client or a member of the client's immediate family has been exposed or receives a positive test result, then obviously in-person treatment is going to be suspended until they are cleared by a medical professional, and any documentation from the medical professional must be sent to Dawn, our district director, at the email shown on the screen, and then make sure to copy Dr. Bellotti as well and your direct supervisor. And then wait for approval from one of those individuals before starting in-person services again. Notification process. Based on the intake interview, the direct supervisor or other designee will notify any other employee, contractor, client, or stakeholder of the potential exposure. So that's just saying that if you have been exposed to COVID or do have a positive COVID diagnosis, then someone from corporate will make sure to reach out to let other individuals know that a provider has been diagnosed with COVID-19. And then anyone working at that location may have been exposed as well. So you don't have to, if you're working at school, like you don't have to reach out to the school. Someone from corporate will reach out to the school. I think Dr. Bellotti mentioned this in the chat, but you can find the updated COVID-19 policy in the SharePoint as well. And then Dr. Bellotti shared the link to the SharePoint also in the chat. Questions on the COVID-19 policy? Nope, okay. Well, I'm going to refrain from showing the CEU sign-out code yet because we still have about 15 minutes left in our journal club time. So if you guys are interested, I can show some of the data from my mask tolerance study. I also have some interesting videos I can show you guys as well. So I'm going to exit out of this presenter view. While I'm switching over, does anyone have any last-minute questions about the Hallie Ertel study or anything that they want to go over regarding the Hallie Ertel study? And again, you can type them into a chat or say them out loud. Nope, okay. Let me go ahead and share my screen again. Oh, that's my full desktop screen. That's okay. I can't see you guys anymore. Can you see and hear me still?
Yes, we can.
Yeah.
Yes.
Awesome. So this was the presentation I did at FABA that was going over, it was an evaluation of graduated exposure procedure to teach extended mask wearing in various settings to children with autism. So given that we only have 15 minutes left, and this was a little bit longer than 15 minutes, I'm just gonna highlight some salient pieces of this presentation, and don't mind the presenter notes at the bottom. Again, this is a presentation I recorded for FABA. So I did go over some of the studies that we had talked about previously. Mine was a little bit different in that it was a 60-minute terminal goal, so a little bit longer than the 5, 10, and 30-minute terminal goal. There was also only one study that evaluated masks during instructional time, so across DTT and NET, adding in that instruction while wearing a mask. So we evaluated that as well. Let's see. And feel free to stop me or ask any questions that you guys have about this study also. So there are 3 participants who were 6, 9, and 5. Again, this study took place across settings because we wanted to look at generalization of wearing the face mask. One was in a behavior analytic clinic, one was in home, and one was in a mock physician's office. And then we did community probes as well. So similar to other studies, we looked at compliance to steps in the graduated exposure hierarchy, and compliance was just defined as keeping the mask on the face which was positioned over the mask and the nose for the targeted trial duration. If the participant removed the mask at any point, so, for example, if they had to like take a sip of water or scratch their nose, but they put the mask on within 5 seconds, or allowed the experimenter to put the mask on within 5 seconds, then we scored that as an instance of compliance. We also took some secondary data on problem behavior in the form of negative vocalizations and also mands for mask removal, because what we ended up seeing was a lot of not physical mask removal necessarily, but a lot of like, I don't want to wear the mask, I want to take the mask off. So we ended up taking data on that. And if that did occur during session, then it was just ignored. The participant was redirected back to the activity that they were doing. But again, we did collect data on it. This is some video of what that may have looked like during a session.
I don't like the mask. I don't like the mask anymore. I said I don't want the mask anymore. I don't want the mask.
So again, a lot of mands for removal, and we didn't include, actually, so this was actually broken down into 2 experiments. I only presented data from the first experiment, but for participants in the second experiment, what we found was there was a pretty drastic increase in negative vocalizations and mands for removal when we switched from teaching during NET to teaching during DTT, which was interesting. And I'll talk about why we started teaching during NET in a second here. I'll show this one. This is it was a 16-step exposure hierarchy that we used to slowly expose participants to longer durations of mask wear. So again, remember this one was pretty significantly longer than the other exposure hierarchies. So it goes from just tolerating the researcher or the parent putting the mask on the participant's face, wearing it for 10 seconds, 30 seconds, and then it increases by 5-minute increments until you hit that 1 hour mark. We didn't have too much to go off of when designing this hierarchy because it has such a long terminal goal. So when we were designing it, we thought that with the 5-minute increments, they could still progress at a quick enough pace through it, but it wasn't so quick such that we couldn't break down a step if we needed to make it, a sub-step, a smaller duration in between 2 steps. Another different piece of this study was we did assessment probes throughout the hierarchy. Assessment probes were conducted every 3 steps, and those were just to see if the participant could progress through the hierarchy at a quicker pace. So with the assessment probe, the experimenter put the mask on the participant's face and basically just collected data until the participant took their mask off. And you'll see, I'll show the data on those, but most of the participants, the probes indicated that they were able to skip a lot of steps in the hierarchy, which saved a lot of time for training mask tolerance. These were the general steps of the study. So starting in baseline, then we trained in the clinic, then in the home, in a mock physician office, then we did our community probes and our maintenance probes as well. For baseline, no programmed consequences for keeping the mask on or taking it off, and then it ended if the participant removed the mask or displayed avoidant behavior in a manner such that the experimenter couldn't place the mask on the participant's face. And this is an example of what avoidant behavior looked like. So the participant's given the instruction, let's put the mask on, and then they immediately, he says, oh no, and then he turns away from the experimenter, so the trial would have ended there. I won't go into too much detail here on the different steps, but again, we started in the clinic. We did a preference assessment beforehand to determine a preferred item to deliver contingent on compliance to a step. If the participant did comply, then they were given access to their preferred item. If they engaged in mask removal, then they were given a break from wearing the mask, but they didn't receive access to their preferred item. Like I talked about before, if they engaged in any negative vocalizations or commands to remove, then they were just ignored and we collected data on it. Similar to the Halber study, the criteria to move to the next step was 2 consecutive trials with compliance, and criteria to fade back was 5 consecutive trials of non-compliance, although I don't think any participants in this study met criteria to fade back. And then again, after 3 steps with compliance, then we conducted those assessment probes. Like I mentioned before, first we taught mask wear during NET, and there were a couple reasons that was done. First, because it occurred in a playroom set, generally NET occurred in the playroom where there were other kids and clinicians present, so it was more important to teach tolerance in that setting where there were other people compared to like private therapy rooms. Also during NET, as you guys know, there's generally less demands placed on the participant. It follows the individual's motivation. So due to that reason, for less demands being placed and following their motivation, we wanted to teach it during NET first. And then we taught mask tolerance during DTT as well. I think this is just a little video of mask wear during DTT. So because this is during DTT, the participant had already mastered wearing it for, I think his NET was 20 minutes. So he had mastered wearing the mask for 20 minutes already.
All right, buddy, what is this? What is it? Shoes? What color?
And again, it's just a really small video segment there. DTT went on for a longer duration of time. So after, any questions so far? Does anyone have any questions? I guess I could check the chat really quick. No questions? Okay. So then we did training in home, and it was conducted via telehealth. And really the purpose of conducting in-home training was so that we could take some data on mask tolerance when the instructions to wear the mask came from the caregiver, because at the time of the study, caregivers weren't allowed into the clinic. So we wanted to collect some data on that. I think this is a video of a little bit of caregiver training. I think it's the end of a teaching trial here.
Where? The camera's going off.
Two.
Oh, good job. Yep. Good job wearing your mask. Tell him good job wearing your mask. Good job wearing your mask. You did such a good job.
And then the third and final setting was that mock office setting, the mock physician's office setting. And we used this as a training setting for a couple reasons. One was because, again, at the time of the study, participants weren't allowed to switch their individual therapy rooms. So this, and again, it took place in a hospital, so we had convenient access to these rooms. Also, all 3 of the participants had they had physician's office visits coming up. They had specialty care visits coming up. So it's actually caregiver requests that we work on mask tolerance in this setting as well. And then last we did community probes. Community probes took place across a barbershop, their piano teacher's house, and also a daycare. And we collected data on compliance and problem behavior. I'll show just a little bit of the community probe for Miles. So this is him at a barbershop. He did great with it. We also did, I know we only have 4 minutes left, so I'll rush through this. We did maintenance probe 1 month following treatment in the clinic setting, where masks were not removed after that 1 hour mark. And we basically just collected data on how long they kept their masks on for. Took some social validity data from caregivers as well on how effective they thought the procedure was, if it was important to them that their child wear a mask while in public, if they found that the procedure was beneficial as well. These are the treatment data. So on the X, you have session, and on the Y is the step number completed. Miles was able to probe up to 1 hour after mastering through 5 minutes in the clinic setting. We started with the in-home probe again when we switched settings, and he probed up to 15 minutes and 35 seconds. So we taught 3 steps up to 30 minutes, and then he probed up to an hour. And then he demonstrated an hour of tolerance in the mock office community probe and 1 month maintenance probe as well. And I'm going to skip through some of these other data because we're running a little bit low on time here, but pretty similar patterns. So training probe indicated quicker progression of tolerance through the hierarchy. For one participant, we did have to switch to a free operant preference assessment because she was displaying what we hypothesized was a carryover of problem behavior from running an MSWO. Let's see. Yeah, so these are the steps skipped. So the assessment probes were very helpful in indicating that all participants were able to skip steps across all of the settings, which was cool. Oh, this was some of the mask touching that we had talked about, like playing with the mask.
Do you have a match?
So you can see he was touching his mask a lot. He wasn't necessarily taking it off, but he was playing with it a lot, which you don't necessarily want. So that should be a variable that future researchers collect data on as well, which I'm pretty sure the Halber study mentioned. And then some of the stuff we had talked about before, but really the main points for this study were potentially exposure hierarchy changes. So those assessment probes indicated that all of the participants could progress quicker through the hierarchy than how it was designed. So maybe doing more assessment probes on the latter end of the hierarchy, or increasing that 5-minute, those 5-minute steps to maybe 10-minute steps or something like that. And also potentially adding in a functional communication response for mask removal, which some participants already had, which you could tell by the video in the beginning, like I don't like it, I don't want to wear it. But some participants didn't have that response in their repertoire. And then obviously, as we're requiring kids to wear these for longer and longer durations, we would want them to be able to ask to take it off for various reasons. And if that turns into a compliance issue, then potentially implementing a multiple schedule of reinforcement or something like that to assist with signaling when mask wear was necessary versus not necessary. I did that really fast. Questions, comments, concerns, anything that you want to talk about that study? I know I went over it very quickly. No? Okay. Alrighty, guys. Well, it is 8 o'clock, so I am going. Oh, thank you very much. I appreciate that. I love including videos when possible. Before you guys go, I do want to share the sign out code with you, which, give me 1 second, that was in the other PowerPoint. The sign out code is 2908, and I'll put that in the chat for you guys.
And that's just something BCBAs need, right?
Yes. Correct. $2908. Oh, and Mackenzie put in the CEU evaluation form, so that's for BCBs to fill out as well. Thank you, guys. I appreciate the feedback. I feel like that was a lot of me talking and maybe not as interactive as previous presentations, but I'm glad that you guys enjoyed it. And then obviously, if you guys have any follow-up questions for me, not even just on this study, but if there's anything that you want to talk about tolerance related in general, I love talking about tolerance. So feel free to email me, or I'm pretty sure everyone has my phone number, so you could text or call me as well. Not even if you want to talk about it, but if you think that potentially this is something that could be helpful to one of the cases that you're working on, I'm more than happy to discuss possible interventions there as well with you and whoever your lead analyst is. Alrighty, guys. Well, I hope you have a great rest of your evening. I hope you enjoyed the presentation. It seems like most of you guys did. Other than that, have a great rest of your night. Thank you guys for coming.
The sign-out code for this presentation is 2908.